Hi to Poland from Slovenia. Hi to Poland. Thank you for giving us the chance to organize this webinar for our customers. I would like to introduce Mrs. Aneta Leventi. She's an export manager. And also hi to Dr. Piotr Vujec,
hello.
Who is going to have a lecture about endodontics. And I will just give a word to you to explain everything. And of course, if there will be any questions, not only during webinar, but also afterwards, we are here in internet to answer all your questions. Thank you again, and please.
Okay, thank you, Urszka. Dear doctors, good morning. On behalf of Endostar and our partner Interdent company, I would like to welcome you on today's webinar. My name is Anita Leventi. I am an export manager. This is my colleague, Alexandra. She's an export specialist, and Alexandra is the main person who is responsible for collaboration with our partner and also with your dental market. Today, we will be responsible for technical points related with this event. So before I will introduce our lecturer, please know that during the presentation, all your cameras and microphones will be switched off. So our contact will be limited only on a chat. So if you will have any question during the presentation, you can write them on a chat. And after the presentation, Dr. Piotr will answer on all of the questions. So now I would like to introduce you our lecturer. Please meet Dr. Piotr Vujec, who is one of our best Polish speaker. And before the pandemic, together with Dr. Piotr, we organized a lot of webinars, a lot of meetings abroad. Now we have to focus mainly on the webinars through the internet, but still it's a great opportunity for us. But we also have hope that soon we will be able to travel and we will visit your country where we can meet each other face to face. Today, Dr. Piotr will be talking about mastering root canal shaping protocol with modern approach. So Dr. Piotr will show you some interesting clinical cases using our Endostar E3 Azure and EasyPath files. So I'm sure that you will be very satisfied. And now I invite you to listen to the lecture. I give the floor to Dr. Piotr Vujec, please.
Thank you very much. Thank you, Aneta. It's a pleasure to contact with you via internet. Yeah, traveling, it's good old times and good memories, traveling with Poland to share the knowledge and to organize hands-on courses. Nowadays, in pandemic times, in Poland, we are starting again to organize small workshops, small conferences. Yesterday and 2 days ago, I was host of the hands-on course for young dentists, and today I got an opportunity to share the knowledge with you. And as Aneta said, mastering root canal shaping protocols. So I will explain you protocols for easy normal canals and also for more difficult cases as well. So let's start the presentation. I hope technically everything will go easily. Again, something is wrong with my presentation. I cannot switch the slide. So just let me have a second.
We see the first slide only.
Yeah, I know. I cannot. I think I need to stop share for a second.
Okay.
Now it changes to the next one.
We still see the first one only.
Okay. And how about now?
Yes, now we see the second one.
Okay. And still I cannot switch to the next slide. I'm sorry for a second. I hope now it will go. Yes.
Yes. Okay. Now
sorry for this. Okay. So the main question at the beginning of this presentation is how flexibility improves shaping protocols, especially in difficult cases when the canals are curved and not easy to enter. And the answer for this question is very short, only 4 letters in English. Flexibility improves shaping protocol a lot. So more flexible file we get, we can reach more in complex and complicated canal situation. So this flexibility is the main point of modern approach of shaping protocols in root canal system. At the beginning, I want to share you some case I did, I think 12 years ago. It was the time where only classic nitride alloy files were available on the market. I was during my PhD study of endodontics, and this patient came to my office, and I started to shape the canal in this upper molar. And you can see here the situation that we got first upper left molar with some periapical lesions and severely curved mesiobuccal canal here. And I, as a young dentist then, I started the shaping protocol with ProTaper next. So I start shaping with the SX file here. And I treat this very difficult case like a normal one. So I had, that time I had only one clinical protocol of shaping canals, the same protocol for easy canals and the same protocol for very difficult ones. And that was my first mistake here, because after a few seconds of shaping with the SX ProTaper, I broke the file inside the canal just underneath the curvature. So I thought, okay, let me finish the preparation in the rest of the canals, the palatal canal, the distobuccal canal, and then I will try to remove this broken instrument, because I had an ultrasonic tips, I had a magnification with my operating microscope. I will try to remove it. And that was my second mistake, because we cannot remove what we cannot see. And behind this abrupt curvature, I was not able to see this broken file. That's why the only thing I did here was the perforation of this root. So at the end of the treatment, I obturate the rest of the canal with gutta percha and sealer, and I obturate the canal up to the perforation and broken file with MTA. And I explained the patient that because of the very difficult anatomy, we had a problem here and an issue with the broken file. And if something happens to this tooth, we can try to remove the mesiobuccal root and save the rest of the tooth. After 2 years, this patient come to my office with some other problem, and I take an X-ray. She said, with the tooth, everything is okay. She cannot feel anything. And as we can compare the direct post-op and 2-year follow-up, you can see that the lesions are a little bit smaller. At least they are not bigger. So I said, according to the European Society of Endodontology, we should wait and check radiographically up to 4 years after the treatment. and then we should decide if we can, if we should do the surgery or if we can leave it like this. Unfortunately, this patient disappeared, so I never had an opportunity to follow this up after more years from primary treatment. So I don't know what was the story of the patient, but I know that I take a huge lesson from this case. First lesson was we shouldn't have one protocol for every case. We should have at least two protocols. One protocol for, let's say, normal canals without abrupt curvatures, and second protocol for very difficult cases. We should have different approach. That was my first lesson. Second one was that more flexible files maybe will manage this curvature. And also in the later part of this webinar, I will show you how can we select the cases if they are easy or moderate or extremely difficult for us to shape and finish the shaping protocol. So next case I will show you at the beginning is the also difficult one. This is also first upper left molar from different patient. You can see that the mesiobuccal and distobuccal root, they are connected together. And I draw you how the root, connected root goes. And I start shaping the canals. And when I remove the file number 10, K file number 10 from the canal after scouting, I see the imprint and the original curvature of the canal on the shape of this K file. And I know that that will be a lot of work and hard work to do to finish the shaping protocol. So I started the shaping protocol, and this is the direct post-op. Everything looks great here. Here is the different angulation. But when we look closer to this second X-ray, we can see some interesting point up here. When the shovel shows us, this is the ledge that I started created with the rotary files. That time I work with the Endostar E3 files, but with the classic nitrile alloy, not the new version, not the Azure files with the modified nitrile alloy, but the classic one. The classic nitrile alloy has the ability to come back to the original position. So when we prevent the file and release, it goes back to the original position. That's why it has a tendency to straight inside the canal and also cut the small ledge on the external curvature. If the canal is curved more, the tendency is higher. So luckily for me and for this patient, I realized that I starting to create a ledge, and then I stopped using rotary files in this canal, and the rest of the preparation was manual preparation with pre-bended stainless steel manual files and crown down technique, and I was able to smooth the ledge, obtain the patency, disinfect the canal, and obturate it. So it was hard times without modified nitrile alloys like we have today. Nowadays, the cases like this we can manage more easily. They are because of the flexibility of the modern files. That was just two cases at the beginning. Before I introduce myself, just 1 minute of introducing myself. My name is Piotr Wujec, and I'm an endodontist. I finished medical university in Łódź. Łódź is the third biggest city in Poland, exactly in the central part of the Poland. After I graduate, I stay there for the PhD study, and also I get my master degree of endodontics and conservative dentistry. I am an active member of the Polish Endodontic Society and also Polish Dental Ergonomics Society. Since 11 years, I am running my practice endodontal microscopic dentistry, And I'm also running a blog, perfendoblogspot.com, when you can follow some interesting cases. At the beginning of this, after these two nice cases, when I mentioned that I managed the case with the old school classic night-eye alloy files, I want you to know just a little bit what are the big differences between the classic night-eye and heat-treated modified night-eye alloy, and how this heat treating changes the properties, physical properties of the night-eye, because it is extremely important to understand the differences between modern files and the classic night-eye rotary files. So night-eye alloy nitinol is a material from 1963. The whole range of the night-eye alloys in the world, but in dentistry we are focusing only on this green field, between 15 and 60% of the total mass with Ni and Ti, because of its physical properties. Around 50% of the atoms of the Ni and 50% of the titanium. So this part is particularly in dentistry and endodontic field. And this alloy, the night-eye alloy, has two phases: austenite phase and martensite phase. The austenite phase, on the left side of the slide, you can see its properties are: it's ordered, it's more symmetric, and also spring to the original shape. When we prevent the file, it goes back to the original shape. So we know that the night-eye in austenite file goes back to original shape, and we cannot prevent the file. It's not so flexible. But when we cool down the austenite classic night-eye, it underneath the 0 degrees of the Celsius, it goes to the second phase. This night-eye alloy goes to the second phase, to the martensite phase. Martensite is less symmetry, is more flexible, and when it gains the temperature from the surrounding environment, it comes back to the austenite phase. So in room temperature, the classic night-eye is in austenite phase, but when we cool it down, it goes to the martensite phase for a few seconds, because when it gains the energy, the temperature from the surrounding, it goes back to the austenite phase. So heat-treated modification is to change the property in a special, let's say, oven for the files, when we can give a proper pressure and temperature to the classic night-eye, and then we can change these properties to have the martensite phase in the room temperature. So we don't need to cool down the night-eye file. After this heat treated, it is in martensite phase in the room temperature. So we can, after this modification, we have more flexible file without any other problems in our office, in our cabinet. So the E3 Azure are the files that were gained with the heat-treated technology, and then this technology changes their physical properties. And nothing has changed, everything is new. It's my sentence, because the shaping protocols, the apical sizes and the tapers are the same like with the classic E3, but everything is new because we changed the properties of the night-eye alloy. That's why it's a new experience working with the E3 Azure rotary files. And when we compare the technology of the Azure modified night-eye alloy, it redesigns the physical properties of Endostar E3 classic night-eye blade. to have a stable phase of the martensite at room temperature. This increases the elasticity and flexibility comparing to the classic nitrile. It's also, we can pre-bend the file if the access to the orifice of the canal is difficult. We can pre-bend that modified nitrile alloy and have this rotary file pre-bended before inserting to the canal. But also this modification keep all positive aspects of Austenite Phase. So it is still strong file. It is also very resistant to the stress that it gains during the shaping the canal system. So it is, you can see on this bending test, it's a movie from our lab that measures how many force we need to put to pre-bend the blade of the file up to 45 degrees. And comparing this force with the classic nitrile, the same size, the same taper, but before the heat-treated modification, the difference is huge. So the elasticity of the E3 Azure file comparing to the classic E3 file with the same size, the same taper, it's like 2.5 times more elastic. And also, normally when something is more elastic, it's also less resistant for breakage. But the proper evaluation of the heat-treated technology also increase the resistance to angular deflection. Here is the also a movie from the lab when the file is locked at the end of the tip of it, and the rest of the file is rotating up to the breaking point. And we are measuring the angle, how many times it needs to rotate to the breaking point. And we comparing the same size, the same taper of the blade from classic Endostar and E3 Azure, we can also see that resistant to fracture is higher after the heat-treated modification. So this technology gave us more flexible and more resistant files to the fracture. So viva la evolution, we are not doing the revolution because the shaping protocols, shapes, tapers, sizes are still the same, but the evolution of the properties, physical properties of the alloy give us a huge step forward, a milestone in rotary shaping of the canal. Before we start canal shaping, I need to explain you some steps before we start canal shaping. So we need to design the introduction to canal shaping. We need to design the endodontic cavity. So this is the slides from the bark hole, horn and circle endodontic textbook, when they showed the classic access and the classic design of the endodontic cavity. Nowadays, with the ultrasonic tips, with the diamond coated ultrasonic tips, we can be more conservative, especially for the pericelvical dentine. But while we are doing, for example, retreatment, sometimes the excess when the tooth structure and the crown structure is severely destroyed can be as big as on these classic files. What is most important here? The most important here is the situation that we remove the overhanging dentine that covers the entrance to the orifice of the mesial canals. So we are creating here the straight line access. And the authors of the textbooks shows the pictures with the Gates Glidden burrs, which are stainless steel burrs, but they are okay when the canal is not severely curved. But because of they are stainless steel, they can cut the ledge on the external curvature of the canal. So better idea nowadays, and the modern approach, is to use a modified Tactile file to create a straight line access as well. That's why in the E3 Azure basic files, we got one file, the Orifice opener, to create a straight line more carefully and more safe. To prepare the endodontic cavity, I use very often this file. It's diamond coated burr with non-cutting tip, especially for the beginners who are not well skilled dentists at the moment. It's very safe because the non-cutting tip saves the pulp chamber floor from perforation, and this file is quite safe. We can close our eyes and let's say draw the black triangle while we are removing the pulp remains from the pulp chamber floor, and then we can use this diamond coated burr just to smooth the cavity wall to have nice and smooth designed classic access to the cavity, to the orifices. So this step, the access design, is an important step because it allows us to locate all orifices in the treated tooth. Without this step, we can have problems with locating all the canals, especially when there are some additional canals. So good visualization after this step give us a possibility to create a straight line access. Otherwise, the file without straight line access will work in hard condition from the beginning. After we create a straight line access and the file goes directly to the root canal, bends only in the original curvature of the canal. It is extremely important when the canals are severely abrupt. If the canals are straight and we skip the straight line access, normally nothing happens. We will be able to finish the shaping protocol even without creating the straight line access. But this is the importance of this straight line access increase while the canals are severely abrupt, and especially in the mesial canals of lower molars. That is the most common situation, that this straight line access is extremely important. You can see here the pictures of the pulp chamber floor. From the left, we can see the orifices. Then, before we are scout the canal and try to measure the working length, we should create a straight line access. We can start with the hand file and extend the shape of the orifice to the corner. Then we can enlarge with gates or rotary files. But still, at the third picture, we can see that the overhanging dentin covers the gray color of the pulp chamber floor. And if there is additional third mesial canal, it's covered with this overhanging dentin. So it is important to have the situation like on the fourth picture, without any overhanging dentine. We can see these lines that connects the orifices of the canal. This is the good clinical situation to start next steps of the shaping protocols. But when we start scouting the canal, we with the manual files, we can have some possible mistakes, especially when we are trying to work and shape the canal manual up to the end without any rotary files. Because at the beginning, we need to use manual files to establish the full working length, to negotiate the canal. But after the negotiation, we can create the glide path with the manual or the rotary file, and then we can go to the rotary files. But if we are not working with the rotary files yet, we are shaping the canals with stainless steel files with the bigger sizes, and they can do some mistakes inside the canal. First mistake is a zip at the end, because the stainless steel file, when it's not pre-bended to the original shape of the canal, it has a tendency to straighten inside the canal and create a ledge that can go to the zip, and zip can go further to the perforation. Also, we can have an elbow. An elbow is the situation when the main constriction of the canal is not at the end, but few millimeters above. So if we are not working with the hot gutta-percha obturation techniques, we will have a problem with the cold lateral condensation to properly fill the elbow-shaped canal. And also, we can have a strip perforation on the internal curvature of the canal, because also the manual file that has a tendency to straight can scrub more the internal part of the curvature, the dentine on the internal part of the curvature, and that can create the strip perforation. That's why rotary files are better idea to finish the preparation of the canal. Also, they are better idea to create a glide path. Glide path is the situation when we scout the canal with the smallest files available on the market, so size number 10, 8, or 6. And before we want to use the rotary files, we need to smooth the canal with the files up to the size, let's say 15, to have a smooth canal wall available for the rotary system. And we can do this glide path preparation with the manual files if the case is not difficult. But more difficult the case is, this glide path creation with manual files will be also more difficult, because manual files can create a ledge on the external curvature, and then we have a problem before we even start to use the rotary files. That's why the new product of the Endostar is the Easy Path. The Easy Path is the single file that can replace the manual preparation of the glide path. And when I got this file to testing, I get love with it, because it has extreme flexibility, high resistance to fatigue. It has also easy passage down to the canal, and it creates safe and fast glide path preparation. This file is not aggressive. This file has nothing to do with dentine scrubbing. It has to smooth the canal and prepare its walls to the rotary system. I use this Endostar Easy Path file for every moderate and curved canal to create a glide path. Of course, when we are treating, let's say, upper central incisor at the young patient and the canal is big, we don't need to use this rotary Easy Path files, because the case is easy. But for all cases that are not easy, this is a very unique file that can allow us to create the glide path quick and easy in the predictable way. It has a special design because it has a variable decreasing taper. It has a taper at the last 4 millimeters, and then it decreases. That gives more flexibility to the file, and flexibility is crucial for the file that should create a glide path. The end of the file, the apical size of the file is 14, so it's almost 15, like comparing to the manual files, but has this variable taper. So after this file, we can go and with the rotary protocol, even when the canals are extremely curved. Also, this file is small, it's flexible, but it's also a resistant file, because the EasyPath has the modified cross section of the file. The core of the file, the center of the instrument, is bigger than with the standard S-file cross section, and that gives more strength to the and resistance to the file that is small, but also it will not get back the flexibility of the file. So it's strong and flexible. And this EasyPath file are also modified in classic Nitrile alloy, but not to the Azure technology, but to amber technology. Different properties, different temperature, and the pressure in the oven changes the classic Nitrile alloy not to the Azure files, but to the amber files. They are more stiff than the Azure files. So with the small size of the file, it is a benefit that it's more stiff, because if we had the same file with the HT technology changed to the Azure file, it will be too flexible and will not have an opportunity to push it inside the canal because it will be too soft. So the amber technology is the great idea for this very small file to gain all the benefits of modified Nitrile alloy. So we can gain the best things from the martensite phase, so extreme flexibility, initial bending, and increased resistance to fracture, and also from the Austenite phase, so elasticity, high cutting efficiency, and resistance to fracture. So this modified file has a great fatigue test records. You can see here with modified EasyPath blade at 20 Celsius degrees, so in a cold, let's say it's a room temperature, and also 35 degrees, let's say it's the body temperature. So this modified amber alloy is more resistant to the file fracture. Also, it has increased the working efficiency, and it not aggressively scrap the dentine, it just smooth the dentine and can work with most endodontic handpieces. We can set the torque and the RPMs on the endodontic handpiece, and then we have a great opportunity and great file that is resistant and extremely flexible. This is the picture provided by Dr. Sławomir Gabryś, my friend, who also cooperate with the Poland company. He is one of the inventors of this EasyPath file, and great credits to him. So one more time, when we want to get all these properties in one slide, this EasyPath file has decreasing taper. So last 4 millimeters has around 4% taper, then it decreases up to 2 or even less than 2% taper. It has safe non-cutting tip, modified cross-section with a more massive core to gain the resistance of the file, exceptional 14 size at the apex, also amber technology, and all these benefits give us the great file to create the glide path. How we can work with this file step by step. So of course, we should isolate the tooth with a rubber dam. I am not starting the endodontic treatment without rubber dam, so it is mandatory to start root canal treatment. Then we should prepare a straight line access. So as I mentioned before, this first steps of the endodontic treatment is the design of the access cavity and straight line access. Then we should try to negotiate the canal with the K file number 10. If it's impossible, we can change to the smaller size number 8 or even size number 6. And we are trying to establish the patency with this small manual file and measure the working length according to our working tools, and then we can fulfill the canal with an irrigant solution to give some more friendly environment for the file. And we should place the Endostar EasyPath instrument inside the handpiece, start rotating it, and insert to the canal, but with the packing motion. Packing motion means that we are going up and down with the little pressure. And let's say the movement down should be longer than the movement up. So for me, it's like 2-3 millimeters down, 1 millimeter up, 2-3 millimeters down, 1 millimeter is up. And then we are flushing the canal, and after 3 or 4 up and down movements, we can clean the instrument, flush the canal, and continue this up and down movements till we reach the full working length confirmed by the apex locator. And then when we reach the full working length with the EasyPath file, the glide path is already created up to the full working length, and we can start the proper shaping protocol with Endostar E3 Azure. Normally, this EasyPath is directly combined in difficult situations, so it's combined with the Endostar E3 small apical files that are designed to work with the crown down technique in narrow and extremely curved canals. But I will now describe you the whole family of the Endostar Azure files. But keeping the data of the EasyPath files, I can show you here the recommended torque and RPMs for this EasyPath. 1 nanocentimeter torque, or if we are experienced endodontist, so you can increase it to 1.5 NCM, and from 300 up to 500 runs per minute for as a rotating speed. And now we are going step forward. Already we have designed the axis. We have created a straight line. We have already prepared the glide path, and so now is the time for the proper shaping protocol. And E3 Azure, E3 means easy, efficient, and ergonomic, is the new system with a modified nitrile alloy. The system is have variety of tapers, and also the taper is marked by the number of stripes. There is only one file with one stripe, and that is the information that the taper of the file is 8%. If we had 2 stripes on the handle, it means that the taper is 6%, and 3 stripes on the handle means that the taper is 4%. So more stripes means we have less taper, and the file is more flexible. And these stripes on the handle are colored according to the ISO colored codification. So 30, it's a blue color. The red color means that the file is 25, yellow it's 20, etc. And they are packed in blisters. They have the safe non-cutting tip of the file, which gives us the low risk of root canal wall perforation or creating the ledge on the external curvature, and also low risk of false root creation. The non-cutting tip requires a smooth canal wall, so that's why we spent a little bit of time during the shaping protocol to create the glide path, because this non-cutting tip requires the smooth canal wall to go inside the canal and enter the canal up to the apical area. Cross section of the file is the S file with 2 cutting edges on the opposite side, and the core of the file is less massive than in cross section of the easy path, but the size and the taper are bigger of the files. That's why less core inside gives us the better flexibility. Also, this place between the cutting edges is the place when the dentine debris goes during the preparation. So it is a great tool to evacuate the dentine debris from inside the canal to the coronal part. This file should work in the RPMs from 150 up to 300. I prefer 300 or even 350 because in my hands it works more efficient when it spins a little bit faster. The cross section, the core part of the file, it's only 63% of the whole cross section. That's why the file is flexible according to the design, and also because of the modified nitrile alloy, it also gives us the more flexible file than comparing to the classic nitrile. This is the slide of the whole E3 Azure rotary system, and we can see we got E3 Azure Basic, E3 Azure Small, and E3 Azure Big. Most canals, the normal canals and slightly curved canals, we can finish the preparation only with the E3 Azure Basic. So this is the heart of the system. The E3 Azure Small are designed to work in the crown down technique in the more difficult conditions when the canal is narrow and when the canal is severely curved. And the E3 Big are just the bigger size of the files if the anatomical conditions are bigger than the biggest file from the E3 Azure Basic. So it is just an extension pack from additional apical sizes of the rotating files. As I mentioned, the heart of the system is the E3 Azure Basic. And we have here a set of 3 files. First file, the only one with one stripe. So as I mentioned, one stripe means 8% taper, and this stripe is blue. So we can also know that the apical size is 30. This is Orifice opener. It is from modified nitrile alloy, so it's flexible, but also it is shorter than the rest of the files because this file, according to its design and taper, should not go to the full working length. It should keep and work in the upper part of the canal. And this file replaced the stainless steel gates, grid and burrs to create a straight line. So it's a great tool to have more safe file and conditions to create a straight line. The next 2 files, they are in 3 different longevities, 21, 25, and 29 millimeters long. It depends which set we want to have according to the clinical anatomy of the root canal system. And the file with 2 red stripes has apical size 25 and taper 6, and the last one is apical 30 and taper 4. And now I will describe you step by step how can we work with this set of the Endostar E3 Basic set. First of all, of course, we should isolate the tooth with the rubber dam. Then we should create an access. Then we should locate the orifice of the canal, and I scout the orifices with the K file number 15 to the slight resistance. At that point of the preparation, I'm not concerned about the longevity of the canal, so I'm not using apex locator to determine the full working length. I'm just trying to understand the anatomy of the upper part of the canal and to create a small glide path to the orifice opener. So I placed the K file number 15 just few millimeters to the slight resistance. I'm not forcing the file inside the canal. If I feel the resistance, that's my temporary working length, and then I took file number 1 and I keep 2 millimeters, around 2 millimeters short than this distance that I reached with the K file number 15. I'm using the brushing motion with the file, so and also I can selectively scrub the wall that I want to straight more to create the straight line access. So I'm brushing with the rotary file inside the canal, but I'm keeping the upper half of the canal. After that, we got a created straight line access. Then I go back to manual files, and I'm trying to determine the full working length and create a glide path to size number 20 with the manual files, or I use the easy path, because not always we need to use the easy path. If the canal is not so narrow and not so curved, we can create the glide path with manual files as well. So I create with the, let's say, number 6, number 8, number 10, and then number 15 and 20. If we don't have easy path and have some problem with the manual glide path preparation, because normally here between 6, 8, and 10, the difference in the size is not so big, because it's only 0.02 millimeter, but between 10 and 15 it's 0.05. So the difference in the size between 10 and 15 is big, and sometimes this is the first problem when file number 15 stuck inside the canal. So sometimes we need to use the unique size files. These are set of the 3 manual files that are the sizes are 12.5, 17.5, and 22.5. So we can use this unique size before as an additional step before size number 15, and then 17.5 before we use file number 20. I'm just mentioning it when we don't have easy path rotary files, because it's the easiest way. The easy path is the easiest way to create the glide path. If we don't have the file, we can also help ourselves in difficult cases with this unique size manual files. Then when we establish the full working length and create the glide path up to the size 15 or 20, now is the time to take the file number 2, 25 taper 6, and this file should reach the full working length, but in some steps. It's not one attempt. We can divide this this movement up to the apical area at the for few steps. So we are introducing this file, always rotating inside the canal, and we are also working with the pecking motion. So 2-3 millimeters inside the canal, 1 millimeters release up to the coronal part, and then again 2-3 millimeters inside, 1 millimeter up. If the file is not going inside the canal, we shouldn't push it. We should remove it from the canal, stop spinning the file, clean it, and irrigate, flush the canal with the sodium hypochlorite. I use 1 milliliter of the sodium hypochlorite between each rotary file or each step of the rotary file. You will see during this irrigation how many dentine debris this file creates. So that's why it is so important to flush it out from the canal. And then with the clean canal with fresh irrigant and clean file, we are we're having second attempt of reaching the full working length. So again, with the pecking motion, we go 2-3 millimeters inside and release until we reach the full working length. Sometimes it took us like 2 attempts, sometimes 3 or 4 attempts, but once we reach the full working length, we should check the working length with the manual file and apex locator. Why? Because this 6% taper sometimes can straight a little bit the curvature of the canal, and the distance between referring points can be a little bit short than in the unprepared canal. Normally, it is around 0.5 millimeters short. So we should change the settings of the longevity on the last file because it is more safe to the apical constriction in the apical area of the canal. So the last file that we use is the file with 3 blue stripes. It has size 30 and taper 4. And because the previous file has taper 6, this 4% taper file will work only in 3 or 4 last millimeters in the apical area, enlarging just the apical area to have better conditions for irrigation. After that, that file we also should check the working length with the file number 10, and also we should check the apical diameter, if the size number 30 is enough, or we should think about enlarging the canal with the Endostar E3 big files. How we can check the apical diameter? We can check it with the manual NITI files with the corresponding size, apical size. So after we finish the preparation with this file, we should take file number 30 with NITI alloy, because stainless steel files can lock in the curvature and give us the false information. And what information we want to gain from this manual file? We want to put this file to the full working length, and we will try to gently rotate the file. If it stays in the stable position and springs back to it and doesn't want to rotate, it means size 30 is enough. But when it's rotate, it means the apical size of this canal is bigger than 30, and we should consider enlarging this this canal and the size of the apical area. This is how it looks on the clinical video. So after I finish the rotary preparation, I am placing size 30 NITI manual file and rotating it, and you can see it rotates. Of course, the movement should be very, very gently, because when we place the force to the file, it will start scrubbing the dentine and rotate. That's why we are just very gently trying to rotate the file at the full working length. Here, size 30 is not enough because of the anatomical reasons. The canal is bigger than 30 in the apical area. So after that, we can place size bigger, 35, also at the full working length. And now, when I'm trying to gently rotate it, you can see it stays in the stable position. It is not rotating. That means 35 is the apical size, and it's okay. So we can finish the preparation on 35 manual, or we can go to the extension pack of the rotary files. The extension pack is the Endostar Azure Big. And this is clinical movie, how we that I captured the video for you, step by step protocol of shaping the root canal with Endostar E3 Basic. Now I'm scouting the canal with the K file number 15, just to check if it's available for the file number 1. Orifice opener. The Orifice opener, size 30, taper 8, and with brushing motion, selectively scrubbing the wall I want to remove the dentine from, and I'm creating the preparing the coronal preflaring. And you can see here on this video as well how many dentine debris and the pulp debris comes out from the canal after this rotary file. That's why it is so important to flush the canal between each rotary file. Now I had a straight line access, and I'm trying to establish the full working length. So I go back to the manual file size 10 and apex locator, and I'm trying to establish the full working length. Once I establish the full working length, I know how deep I should go with the next rotary file, But before I use the next rotary file, I will create a glide path for it, because as you remember, Endostar E3 Azure files has non-cutting tip, so the canal wall should be smooth. So now I'm preparing the glide path with the manual files. It's easy and quick in this case because it's a upper lateral incisor, so the canal is quite straight. I don't need to use EasyPath here. And after a few seconds, I got size 20 up to the full working length, and the glide path is created. And I'm ready now to use the next step of the rotary files, 25 taper 6. If the canal is big, you can reach the full working length with one attempt. But if the canal is not so big, it's smaller, divide this movement, and it's called step, let's say step down. So now I'm feel the resistance, I remove the file, clean it, flush the canal, and with the second attempt, I'm ready to reach the full working length with 2506. You can see how many pulp debris and dentine debris I have in these grooves between the cutting edges. And now Endostar E3 Azure size 30 taper 4, the last one at the full working length, and you can see it works. The debris are only on the 2 or 3 last millimeters of the file. Then I'm checking the working length, and I'm confirming the working length with the apex locator and corresponding size manual NiTi file. And also I'm trying to confirm I'm doing the apical gouging. So I'm checking if the size 30 is enough. So when I'm trying to rotate the file, it gently, it stays stable in this position. So I can finish the preparation on size 30 and taper 4. So now the canal is ready to go step forward in endodontic treatment for up to the final irrigation protocol, and then obturation protocol, and finish the treatment. If size 30 is not enough and 35 manual NiTi also is not enough, it's rotating, then we can use the extension pack E3 Azure Big. The E3 Azure Big is an extension pack, additional sizes for rotary files, because 3 of them has the same taper, 4%, but the difference is in the apical size. 3 green stripes is 35, then is 40, and the biggest one in the set is 45. So we have 3 additional sizes if the clinical situation is more big than size 30, and we can use this. We should use these files always after we finish the preparation with the Endostar Azure E3 Basic, and after apical gouging, we can make a decision. Yes, the canal is bigger, we can use E3 Azure Big. If the canal is bigger than 45, for example, patient is young and we need to treat upper central incisor, the rest of the preparation, the apical preparation, should be the manual preparation. So size 50, 60, 70, or 80, or even bigger, there requires the manual preparation of the apical area. But the most of the canal walls are prepared with this E3 Azure Big files. Even according to that physical properties of the heat-treated alloy, the files are big in size and taper, but they are still flexible, and that's why they are safe to use in our conditions, in clinical conditions. And this is the second clinical movie that I captured how I work with this Endostar E3 Azure Big. So this canal has already been shaped to size 30 taper 4 because I finished the preparation with the Endostar E3 Azure Basic, and according to its size I decided to use E3 Azure Big. So first file 35 taper 4, it goes to the full working length. Important step, 1 milliliter sodium hypo between each rotary files to flush out the dentine debris and also to access the time of for the sodium hypochlorite to to act in the canal. Second file and the Endostar E3 Azure Big is 40 taper 4. Also packing motion. Once we reach the full working length, I remove the file, flush the canal with the hypo, and before I use the biggest file in set, I am determining the apical diameter. So I'm doing this apical gouging, if it rotates or not, and according to this apical gouging, I made my decision. If it rotates, I will take the biggest file in the set, 45 taper 4, and it rotates just a little bit. And during this procedure, I can also confirm with the apex locator the working length. And then I decided to use the biggest file in set, 45 taper 4. And also packing motion up to the full working length, and then I'm confirming again everything. So the apical gouging with file 45 and confirming the working length with apex locator. And then I finished the preparation of the canal. Canal is ready to final irrigation protocol and then obturation protocol. So we can see here during this apical gouging, this file, the corresponding size of the manual nitrile file stays in the same stable position, which means this size 45 is enough to finish the preparation. So it is quite easy to understand the differences between E3 basic set and E3 big set. The basic set is the heart of the system for normal and slightly curved canals, and the big set is an extension pack for this E3 basic in cases when the canals are big. It is easy combination between two sets of the rotary files, but more difficult cases requires different approach. That is what I say to you at the very beginning of the lecture when I was describing you my failure, because with the broken pro-taper inside the canal, because that time I had only one approach for every single case. Now for the normal canals and big canals, it's E3 basic and or combined basic and big. And for the small canals, it's EasyPath and Azure small set to be able to finish the preparation of even severely curved or S-shaped canals. This E3 Azure small set contains 3 files with small apical sizes and 2 different tapers. File with 2 yellow stripes is apical size is 20 and taper 6. A file with 3 red stripes is apical size is 25 and taper 4. And file with 3 yellow stripes, the smallest file in the whole set, taper 4 and size 20. Sorry, not taper 20, but size 20. So it's the smallest one, and also according to the modified heat-treated nitrile alloy, extremely flexible file. So if we use EasyPath to create a glide path, we get 14 size after EasyPath and variable taper. This smallest file will also gain the full working length for sure. And also these files are designed to work in a crown down technique. So first two files will create some space for the smallest file in the upper part of the canal, and the smallest one will be able to reach the full working length as a first rotary file that scrap the dentine. And here is the slide when I will show you step-by-step procedure how can we safely use this E3 Azure Small with the crown down technique. So normally when we are not experienced with the system, we should always start the shaping protocol with E3 Azure Basic, because the information from this system gives us the information from the file, give us the information, are we able to finish the preparation with basic set, or we need to switch to the small set. Once you gain the experience with the system, you can skip in clinical situations this step, because after you take the pre-operative X-ray and you will see that the canal is severely curved, you can make a decision at the beginning, I will need the Endostar E3 small set. But without experience, please start with this E3 Azure Big. So of course, rubber dam isolation, access creation, straight line access with file number 1. Then we are trying to establish the full working length, and we are creating a glide path, and we are starting to prepare the canal with the rotary file number 2, 25 taper 6. In normal cases, it goes like 2-3 millimeters inside. We clean the file, flush the canal, and go again, and it goes and it reaches the more distance in the canal. It goes deeper inside the canal lumen. But if the canal is too narrow or too curved, it will stuck in the same position. Even if we flush the canal again, clean the file again, it will also stuck in the same position. This is information for unexperienced users that we are not able to use this set to finish the preparation because canal is too narrow for the basic set. And this is information to switch into the E3 Azure Small. And as I said, once you get the experience of the system, you will know it from the beginning, so you can skip this step and start from this point. First file that will go and work in the upper part of the canal is size 20, so small size, but taper 6. So it is also, we can call it micro opener for the orifice. And then we are going step down or crown down with the next file. It has a bigger size because it's 25, but it has smaller taper because it's 4% taper. That's why this file is more flexible, and it shouldn't reach the full working length. It should go just a little bit inside the canal to create more space for the last one, the smallest file number, file with 3 yellow stripes, so size 20 taper 4. And this file gets to the full working length as a first rotary file, but size 20 taper 4, it's not enough to finish the apical preparation because it will not create enough space for proper disinfection of the canal. So once we reach the full working length with the smallest file, we are going back to the previous one, to the size 25 taper 4. And in this attempt, we are trying to insert this file to the full working length. Once the smallest one create a space in the apical area, this file 25 taper 4 will have an easy access to the apical area. If the size 25 goes hard inside the canal because the canal is severely curved, we should, but at first, second, third attempt, finally we reach the full working length, we should finish the preparation at size 25 and taper 4. But if this files goes quite easy to the full working length, we can consider to take the last file from the E3 basic, size 30 taper 4, and try to prepare the canal at the full working length with this file. So it depends. If size 25 taper 4 goes quite easy to the full working length, go for it. This size 30 taper 4 should also reach the full working length, and then the conditions for irrigation in the apical area will be better. But if size 25 taper 4 has a hard work to do to reach the full working length, skip this, because the risk that the file 30 taper 4 will fracture in abrupt curvature is high. That's why it depends according to the case situation. So this is the approach for narrow and curved canal. So we got the weapon for the whole range of the anatomical situations. Now I would like to share you some interesting cases when I use this Endostar E3 small and also basic combined with big. This case, I took the post-operative X-ray because I was treating here the upper right molar, and this is just after I finished the endodontic treatment. You can see the S-shaped canal in the mesiobuccal canal. But what is the most interesting here is the second premolar that has that pin that goes out the tooth structure and goes to the bone, and also the canal axis is quite difficult here. But the time I finished this endodontic treatment of the molar, everything was fine. That premolar was asymptomatic. I explained to the patient that it looks so weird that if something happens with the tooth, I think the best way is to extract the tooth and prepare some implant or fixed bridge. It depends what are the expectations of the patient. And after, I think, 7 months from this situation, when I finished the treatment of the molar, the patient came to my office with the huge swelling in this premolar area. So we decided to remove it, to extract the tooth. This is the picture of the extracted tooth. You can see that pin that goes out, and also you can see the huge leakage between the composite restoration of the crown and the root structure. So the tooth was extracted, and after a few days of the extraction, I told to the patient we will prepare the first premolar because it looks weird on the X-ray. We will do the retreatment there, and after that we will place the fixed bridge because the patient doesn't want the implant here. Also, conditions for implant were not very good according to the sinus area. So let's have a look one more time on the X-ray. The first premolar on the right side, we can see here that we have some 2 canals obturated, but the end of the root is just at the end of the X-ray. So these 2 obturated canals are not in the center. If you see something like this on the X-ray, normally it means there is some additional canal in this area. That's why the canals you can see on the X-ray are not in the center part of the root. And that was right. This first premolar has a anatomy molar-like anatomy. So we got 2 buccal canals and 1 palatal canal. These 2 buccal canals are located not far one from each other. They are very close to each other, and I shaped them disinfect and obturate with the gutta percha and continuous wave obturation technique. And directly after I obturate the canal, I take a direct post-op with the rubber dam to see the beauty of the abnormal anatomy, and then I prepare a space for the fiber post. And after the fiber post placed, we wait a few more weeks to have a bone healed after the extraction of the second premolar, and then I prepared the fixed bridge on these two teeth. And second interesting case from my office, when I used the combination of Endostar E3 Basic and Endostar Azure Big. This is the panoramic picture of the patient. The first look when we see this panoramic is, of course, on tooth number 38, 37, but I was not able to help this in this area, so the patient was referred with this tooth to oral surgeon to extract the tooth number 8 and number 7 because of severely destroyed of the root tissue. But he also complained in the area of the tooth number 16 and 17. Tooth number 17 was very destroyed. This is the picture of the small frame X-ray when some dentists remove the metal post from tooth number 17. But you can see here also huge bone loss from the distal part of the tooth. So I explained to the patient that probably there is a root fracture, which is the cause of the bone loss, and that was true. Under the microscope, I investigate the VRF, so vertical root fracture. So I told the patient, listen, this tooth needs to be extracted. I cannot help you with it, but I can help you with the first molar, tooth number 16, because on this X-ray, you can see also a huge periapical lesions, very big lesions in this apical area. And that was because it had this tooth had 6 canals. This is the picture that I took when I was preparing the endodontic cavity and was cleaning the pulp chamber from the old obturation material. And now we can count the number of the canals here. This is the MB3, this is the MB2, this is the MB1, this is the distobuccal, mesiopalatal, and distopalatal. So we, in this case, we got 6 canals. Maybe this is the reason why these periapical lesions are so big on the X-ray. So what was interesting here, I started the shaping protocol with the Endostar Azure Basic and Big in the palatal canals. And on the right side on the picture, you can see the whole beauty of the complexity of the root canal system. Palatal canals were merging, they were connected together, because when I take the irrigant from one canal, also the level of the irrigant in the second canal decrease. This is for us the clinical situation, the confirmation of this merging point. And I was also surprised because I suspect the same situation in the mesio MB1, MB2, and MB3. So I was very shocked when I investigate that MB3 is not connected with the rest of the canal, MB2 as well, and MB1 as well. So we got 3 separate canals in MB root, MB1, MB2, and MB3. Extremely rare situation. This is the picture when I with the master points before the obturation, and you can also see on the left X-ray that 2 master points size 35 taper 4, because I used Endostar E3 Big files here. They are merging in the apical area, and this is the picture with the master points that are placed inside the canal at the moment that I was measuring and fitting master cones here. I'm doing this during irrigation protocol, when after I removed the smear layer with the citric acid, and I'm disinfecting the canal with the proper amount of the sodium hypochlorite. On this step, I also fit the master cones, because master cone should go up to the full working length, and we should feel the tack back, the resistance, while we are trying to remove it. The benefits of fitting master cones in sodium hypochlorite is, first benefit, we will disinfect the master cone with the sodium hypochlorite, and second, the conditions inside the canal are very like the same like in the situation when we place the sealer with the master cone. So tack back in empty dry canal, we can have a tack back, but when we place the master cone with the sealer, we will not have the tack back anymore. But if we fill the tack back, so the resistance when the canal is fulfilled with the sodium hypochlorite, we will for sure have also tack back with the sealer. And the X-rays in two different angulations show us the beauty of the canal. Two palatal canals, one distal buccal and three mesiobuccals, MB1, MB2, and MB3, but they are so close one to each other that even in two different angulations we cannot see the whole beauty of it. After a few months, this patient comes to my office to do the retreatment of the premolar tooth number 1-5. So I had an opportunity to, after I finished this premolar, to see on the X-ray what's going on with the bone, and you can see how this healing goes nice here. The time difference, sorry, between two different X-rays here are I think 4 months, and after 4 months we had a huge healing progress in the bone area, according to the proper disinfection of this and obturation and shaping protocol of this difficult anatomical situation. And this Endostar E3 files give us also the opportunity to use some very modern approach to curved or S-shaped canals in different way that I showed you and mentioned just a few minutes before. So we can use E3 Azure small files in a crown down technique, but according to its properties and according to its modified HD technology, we can also use it with a technique more, it's called the tactile controlled activation, TCA technique. But before I describe you the TCA technique, I want to describe the classification of the canal, because after the X-ray, we are not sure sometimes if the canal is easy, moderate, or extremely difficult. So we, of course, before we start endodontic treatment, we always should do the preoperative X-ray, and on this X-ray we can try to evaluate the Schneider classification. Schneider classification is the angle between the main canal axis and the apical line. Apical line goes from the apex to the beginning of the curvature, and we are drawing these two lines and measuring the degrees, the angle between two axes and two lines. And if this angle is underneath 10 degrees, it means the case is easy. For sure, we will manage it with E3 basic set. If the files the angle is between 10 degrees and 25 degrees, it depends. Sometimes we will finish the preparation with E3 basic, sometimes we will need E3 small apical. It depends also from the size of the canal, not only the curvature, because big canal with big canal lumen and 25 degrees of the Schneider classification will also be, we can also finish the preparation with E3 Azure basic, but if it's narrow, we will need the small set. But every case that in Schneider classification has more than 25 degrees is difficult one, and for sure we will need easy path and small set. But Schneider classification is not only the criterion of the Schneider classification is not the only one that we should measure on the preoperative X-ray, because here on this slide we can see that the tooth on the left and the tooth on the right has the same angle, 60 degrees. So according to the Schneider classification, they are the same, but we are sure that the tooth on the right hand will be more difficult than the tooth on the left hand, because of the radius of the curvature. So if the radius of the curvature is smaller, the case is more difficult. The complexity of the case is more difficult. So not only the angle according to the Schneider classification, but also the radius. And the third thing we should also investigate on the preoperative X-ray is the distance from the orifice. Because here on the left is my first case that I show you today at the beginning, how I do the wrong thing and the wrong treatment, because it is on the left side when the curvature, the distance from the orifice to the curvature is not big. It is more in the coronal part than the apical than in the apical part. It is more difficult than when the curvature starts in the apical part. It's because of the file design and file taper. In point of 14 or 13 millimeters from the end of the file is quite big, and at the last 3, 4, 5 millimeters, the file is not so big, so it's more flexible, and we have more chances to shape the curvature that is located in the apical area because of the taper, the connectivity of the rotary file. So one more time, here we have a clinical situation, the preoperative X-ray of the second upper left molar, and we can do the radiological evaluation of the case. So we can draw the lines to measure the angle according to the Schneider classification. Then we can draw the radius, and we can mark the beginning of the curvatures. So we can also measure the distance between the orifice and the beginning of the curvature. And we got 3 different informations here, and also we can choose the proper approach. And for here, the proper approach was the Endostar E3 small set in a crown down movement because of the complexity of the case, but it was not so difficult because here we have quite big radius of the curvature, but also look where is the lateral canal located. It is located at the point that the curvature starts, but because of the big radius here, this curvature is smooth, and smooth curvatures are more easy to manipulate, more easy to gain a success, and our success for sure is the ability to prepare the canal to the full working length, then disinfect the canal and obturate it. And the second case, with the abrupt curvature in the last millimeters, that was the time that I shaped the canal with E3 Azure classic files, because E3 classic files, classic Nitile files, because Azure were not available on the market yet. But according to the crown down technique, it was also safe and predictable to shape that abrupt curvature. And look here, also MB1 and MB2 canal are merging exactly in the point when the curvature started. Here, the distance from the orifice is our information that it be easier if the distance is in the apical area and not in the cervical area. And also sometimes we have to deal with the S-shaped files. For example, also retreatment of S-shaped files. Like in this lower premolar, we can see some periapical lesions and obturated canal. I'm afraid when I see on the preoperative X-ray cases like this, because I know that there was some mechanical problem during the shaping protocol, because we can probably someone create a ledge in the apical area and this canal is not straight, it's S-shaped, so we have a problem here to just bypass the ledge in the apical area. So I managed the case. I removed the old gutta percha and prevent the manual files according to the technique described by Theodoros Lambrianidis, the very good Greek endodontist. He described in his paper on Endodontic Journal how to prevent the manual files to smooth the ledge in the last apical millimeters. So you can see the file is straight and only in the last 2 or 3 millimeters is pre-bent with some radius. And then we should try to locate the part of the canal behind the ledge. Once we get there, we should smooth a little bit up and down with the manual file. And then the next sizes of the file, size 10, size 15, and 20, also should be pre-bent exactly in the same way. And normally, in case like this, when the canal is S-shaped and is the ledge to smooth in the apical area, the apical preparation is the manual preparation, because even with the rotary file with heat-treated alloy, the rotary file will hit the ledge and create a problem. So only stainless steel files prevent in the way you see here can manage to bypass this ledge in the apical area. Me and the patient in this case were very lucky because that are one of the most difficult clinical cases to maintain when the ledge is in behind one curvature and before the second one. And that's why it is important to prevent the files when the manual files while we are working inside the canal. And at the end of this webinar, this presentation, I will share some information about additional technique that we can have in our portfolio, let's say, as an endodontist, to shape abrupt, extremely curved canals. The technique is called TCA, Tactile Controlled Activation, and it was described by Antonis Chaniotis, who described the technique according to the different rotary file system, but also heat treated. So we can adapt this TCA tactile controlled activation always also with the Endostar Azure small files. The technique is quite interesting. When we see the curved canal, we are creating a straight line access, and we are measuring the longevity of the canal. Then we are creating some glide path, and then we are placing the smallest rotary file available. Here, Antonis Chaniotis described the case on the basis of the HyFlex files and size 15 taper 5, but I am using the smallest one, the smallest Azure size 20 taper 4 file for the in the same conditions that he described. So we are measuring the full working length on the file. We place the file to the endodontic handpiece and place the file inside the canal lumen without spinning, without rotation, to the first resistant point. And when we have the resistant point, we are then turning on the endodontic handpiece. It starts rotating, and we are doing 2 pecking motions and removing the file. Clean the file, flush the canal again. Now we will introduce non-rotating file to the canal, and this time it will go that 2 millimeters deeper. And again, when we feel the resistance, that is the information for us to start the rotation. When we start the rotation, again, 1 or 2 strikes of the handpiece and remove it from the canal. Flush the canal and repeat this step up to the full working length. Then change the file for the bigger size and continue the idea of entering to the canal space without rotation and start rotating in the first point of resistance, and do just one or 2 strokes with a rotation movement on. And now I will present you the movie that I captured with this technique in the plastic block with J-shaped canal. And what is also worth mentioning, I was not creating glide path here. I was just measuring and scouting the canal with file number 10. And directly after this, I used rotary file from Endostar E3 small, size 20 taper 4. As you can see, I'm inserting it to the resistant point without rotation. Then I activate it, 1 or 2 strokes, and remove it from the canal. Again, without rotation to the resistant point, 1 or 2 strokes, deeper in the canal. And also, I was not flushing this plastic block with anything. And you can see after few attempts, I reached the full working length. Then I switched to the bigger size. And with the bigger size, I think 2 attempts were enough. Maybe 3 attempts were enough to finish the preparation to have a size 25 and taper 4. Of course, this technique requires to use new set of files. If you want to do the TCA with the Endostar files and the canal is severely curved, take the new set of files. And also, everyone who ever had contact with the plastic block, you know how easy it is to create a ledge on the external curvature. And here, this movie improves the ability and the flexibility of the file, because I didn't create here the glide path, I didn't flush the canal between the rotary files, and I didn't cut any ledge on the external curvature. I was able to maintain the patency only with rotary files. So this TCA technique adapted to the rotary Endostar Azure file, it's also available as an additional weapon or maybe interesting technique. Maybe sometimes you can also try it at home and not at home, but at the office, of course, and see how great it works. Sometimes we can only smile when we see the X-rays, because I think when we have an X-ray like this, even a dental surgeon will have a huge problem to extract, to remove the teeth like this. So we have a perfect tools, perfect Endostar files to cover almost all difficulties and have some different approaches according to the clinical situations. But sometimes we are not able to do anything with the case. We are not gods. We can try to do something, but in cases like this, it is undoable. At the end, I want to thank you very much for your attention, and also give you the information that all attempts of this webinar have a 20% discount for Endostar products via Interdent distributor in Slovenia, and it is valid till 7th of June this year. So if you want to try products from Poland, I strongly recommend you to use this voucher, because it's an occasion for you. Thank you very much for your attention. And if you had any questions, now the ladies from headquarters give me the information.
Yes, thank you very much, Dr. Piotr, for very nice presentation, for your knowledge. I saw that we don't have any question on a chat. So I think if any question will appear after the presentation, all doctors, all participants can send them to the Interdent company, and we will try to answer on them together with Dr. Piotr. Thank you very much for your time, and I think we can end our meeting. Thank you very much for participation.
I would also like to thank you, Dr. Piotr, for a nice lecture. Thanks for giving us, of course, this opportunity. I'm still asking participants if maybe there is a question, but now you use the opportunity. Otherwise, of course, like Anita said, you can send it to our email, and we will forward to Poland and to Dr. Piotr.
Okay.
Otherwise, of course, we are inviting you also to use this voucher. You can also get in contact with our salespeople on the field, or you can contact us directly to the company. So,
okay, I see there. Yes, there is one question for Dr. Simliana. Can you please mention all the E3 Azure instruments once again? But this is the question about the sizes of the instruments.
I think we can say that the whole information about the E3 instruments are available on the website, the endostar.eu, when there are some leaflets and all information about the torques, speeds, and everything. So you can download it directly from the website endostar.eu.
Yes, exactly. And also when you're buying our products, there is instruction inside to the package where is also mentioned all information about files, about the sizes and the taper as well.
Otherwise, we will also send an email in, let's say, a couple of days where you will get some information, and we will also put there the link to the catalog, so you can check it there as well. And I would just like to remind something: if there are questions and you are afraid to ask in English, you can also ask in Slovenian or Croatian language, and I will translate. Well, I will try to translate. Otherwise, we will inform you about the A3 Azure instruments by email as well. Maybe some other questions?
I don't see any new questions.
Okay.
Okay, I think there is no more questions.
Okay, so thank you one more time for your attention and have a nice week.
You too.
Yes, thank you very much.
We hope for better weather.
Okay, thank you, bye-bye, stay safe.
You too, bye.